Hi, dear colleagues. This is Şengül Özdek from Ankara, Turkey. I would like to first thank to the organizers of this meeting for having me here. I will talk about vitreoretinal surgery for ROP. You know, pediatric vitreoretinal surgery has a different philosophy. It has its own rules, own complications, does not forgive faults, and does not accept apologies. It's a very small eye, but it's not only the smallness, the lens is relatively large, and pars plana is not developed, sclera is thin and elastic. Posterior hyaloid is tightly attached. Retinal breaks usually end up with surgical failure. And in addition to all of this, we have amblyopia problem. And in vitrectomy, we always try to do lens-sparing vitrectomy if possible. But if not, lensectomy, vitrectomy may be an option. You can do 2-port, 3-port entry or any gauge, but my personal choice is 3-port vitrectomy with 25 gauge vitrectomy. So at the very beginning, the space is very narrow, interpalpebral rim is very narrow. This can be widened with a small cantotomy so that you have enough space to move the eye. And sclerotomy construction is one of the important steps of this surgery. And we start with 1.5 millimeter from the limbus, and till 3 years of age, we increase every year a little bit from the limbus. And we can do either limbal or trans-iris root entry if we are planning to do a lensectomy. But of course, if we are planning to do a lens-sparing vitrectomy, pars pellicata entry is much better. You see, without trocars, with trocars, limbal entry, and these are pars pellicata entry with trocars. So the selection of the sclerotomy site is also a very important step in these cases, because you should avoid from the retina, which is direct into the peripheral pars pellicata area. And while doing the sclerotomy, you can cause a retinal break, and this may be a failure. So you should avoid from those fibrovascular tissue. We always do conjunctival peritomy, and we always suture all the sclerotomies. And you may even think about doing all nasal entries if the retina is in the temporal part totally. As you see here, we put the infusion cannula in the inferonasal side. So the main principles of vitrectomy is to relieve the traction as much as possible, to remove the vitreous and fibrovascular tissue as much as possible. I use triamcinolone a lot. In these cases, more than once, twice, thrice. And posterior hyaloid removal in the posterior pole must be attempt, but you shouldn't insist on it. Because if you insist on it, it may cause formation of a retinal break. And we always try to preserve the lens. And coming to the stage 4A ROP surgery, as you see here, we entered the eye and then do the vitrectomy, try to remove those vitreous membranes as much as possible, causing traction. As you see here, there's traction retinal detachment in the nasal area. Macula is quite nice. We give triamcinolone to see the vitreous better and try to detach the retina if possible without insisting on it, because removing the posterior hyaloid gives us the avoidance of late posterior hyaloidal tractions, which may be a later problem. And this was the post of this same case. You see 4 years afterwards, you can have useful vision. This is 364A retinal detachment, and this is post-op appearance. We don't peel the membranes in stage 4A, but 4B, we have to, because in this case, as you see here, retina is dragged totally to the back of the lens in the temporal side. We had to do lensectomy to remove those membranes in the temporal periphery, and we have to do membrane peeling. Otherwise, it's not possible to relieve those tractions in stage 4B cases. And this is the end of the surgery. And although macula is direct to the temporal side, 8 years old and now 0.2 vision, and retina is nicely attached. Another stage 4B case, as you see, this is post-op 2 years appearance, so the fovea could be attached nicely. Another 4B fellow eye was already stage 5, and we had to open that membranes in the macular area without causing any retinal break. We always leave the eye in air at the end. We relieve the tractions, leave it alone. It usually attaches within weeks itself, as you see here. And this is the post-op appearance of the same case. Retina was nicely attached. This is the most typical surgery where the surgeon should know where to stop. You know, perfect is the enemy of good. So do not let any iatrogenic retinal break formation. But if you have a retinal break, if it is in a silent area, go on with the surgery by relieving all the tractions in the retinal break area. But if it is in the most proliferated area, like in the rich area, you may even quit the surgery. But if it is in the peripheral part, external buckle sometimes may help, a good option. So this was a stage 4B case. We removed the membranes and the subhyaloid hemorrhage, but while doing that posterior hyaloid removal, we ended up with a very small retinal break, which is not in the most proliferated area. And then we did laser, gave only gas, and as you see here, retina was attached nicely. So we have collected our data in stage 4 cases, and we looked at the parameters affecting the postoperative success of the surgery in stage 4A and B cases, and we have seen that results were much better if the eye had some preoperative treatment like laser or anti-VEGF, and if the eye had lens-sparing vitrectomy, and if there is posterior hyaloid detachment. But the results were poorer in eyes with pre-op laser, pre-op plus disease, post-operative vitreous hemorrhage, or iatrogenic retinal break, or if there is a need for lensectomy. So coming to the stage 5 cases, you know, the surgery is questionable in these cases with only very low visual expectations like light perception or so. And the fellow eye, if the fellow eye is good, these eyes are usually not operated. We suggest that the stage 5 eyes should be further graded. For example, if the retina is ophthalmoscopically visible, they can be called as stage 5A, or if it is total leukocoria associated stage 5, it may be called as stage 5B. And in later, you know, they cause corneal opacification within months and years, and then these eyes can be called as stage 5C. I don't operate these stage 5C eyes. So this is a stage 5B eyes with total leukocoria, as you see here. What we do, we try to remove those membranes, dissect those membranes layer by layer with patience very carefully. When you reach the retina and relieve the retina, it goes backwards. As you see here, we try to remove those membranes as much as possible, and you end up with something like this. And then you leave the eye in air, and then you can think about stage surgeries for these stage 5 eyes. As you see here, retina goes backwards within months, and then you can do some more membrane removal, and it can end up like this. This was my best stage 5B case, but sometimes it happens, you know, with good vision. So we have collected our data, and it is recently published in Retina, and the success was around 30%. But when we divide the groups into stage 5A and B, the stage 5A cases did much well, like 60% of them almost reached to some anatomical and functional result, but it was only 15% in stage 5B cases. Even the cosmesis is another important goal for this case, because if it is not treated, you end up with corneal opacification, but if it is treated, the cosmetic result is nice. So stage 5A, 5 eyes can be treated. Better results can be obtained in stage 5A cases, and even unilateral cases can be operated for cosmetic purposes, but families should be warned that they should expect realistic expectations. Coming to the cicatricial ROP, cicatricial cases may have rhegmatogenous or tractional retinal detachment in adulthood or adolescence. And if they come with rhegmatogenous retinal detachment, these detachments are very complex, and almost 2/3 of these patients who underwent vitrectomy had poor postoperative visual acuity. This was such a case. You see, the left eye was a better seeing eye, but it ended up with rhegmatogenous retinal detachment. This was the post-op result after a very hard vitreoretinal surgery. For tractional retinal detachment in cicatricial retinal ROP, we should ask, should we operate or not operate? Because we may risk the present vision already. Is the retina detached since neonatal period? Will it be possible to get a useful vision if anatomical success is achieved? So we should ask these questions. Sometimes no surgery is better. And this was a 6-year-old boy with cicatricial ROP. Vision was 0.1. I have operated in 2015. As you see here, macula was in the superior and temporal ectopic macula, but I can see that there's anteroposterior traction in the superior periphery. So when I relieve these membranes effectively, I know that I could preserve this vision in near future also. You don't have to peel all the membranes, but peel as much as possible, relieve as much as possible. And I could do this without doing a lensectomy. So a lens-sparing vitrectomy was possible. So this is the result. You see some remaining membranes, but no problem. But even after 4 years, vision was 0.3, quite good. So another case, 6.5 years of age, and he had no treatment before. You see bilateral inferonasally direct retina, macula was off, vision was just 0.1. So what we did is just lens sparing vitrectomy. Although this membrane was going to the back of the lens, it was an anteroposterior traction. We could do lens sparing vitrectomy, and these anteroposterior tractions could be relieved much better than tangential ones without having so much risk. So probably this macula was detached later in life, because when the eye gets bigger, the fibrotic tissue doesn't get bigger, but it pulls more, and then it causes macular detachment later in life. So when you just relieve those tractions, you can leave a small part in that in small part of the membrane, no problem. But you relieve the macula, then the result is quite nice, satisfactory. 0.7 vision after 3 years. You see, the macula is nicely attached. Same thing happened to the left eye. Vision improved to 0.3. So vitreoretinal surgery may lead to very good anatomical results in some of the selected cicatricial ROP cases. This is published last year. So my take-home messages are: premature babies need lifelong follow-up, and rhegmatogenous retinal detachments are really complex in these eyes, in cicatricial eyes, and surgery may be very useful in some of the selected cicatricial ROP cases with tractional retinal detachment. Thank you for your patience, and I would like to meet you all in person in Better Health Days. Thank you.